Hello and welcome to Sureena Speaks, and today this video is going to go through high-risk medication. Now there are numerous high-risk medications, but I'm going to try and summarize some of what I think are the key few. Now high-risk medications, it's in the name, they're high risk, so there's extra monitoring and counselling points that go along with these medications. So to start off with, we have our anticoagulants. So we have our classic examples such as warfarin, or we have our new oral anticoagulants such as dabigatran, rivaroxaban and apixaban. Now the benefit that the NOACs have over warfarin is that they target only one specific clotting factor. This makes its effects more predictable, and thus there's less restriction on diet and other medication that the patient may be taking. Whereas with warfarin, there's a lot of counselling points in terms of diet and if patients on numerous medication that we need to give them advice on. So for example, they shouldn't have cranberry juice, avoid green leafy vegetables. Warfarin can interact with NSAIDs, with omeprazole. And the thing with warfarin is that if a patient is on warfarin, their INR needs to be measured at least every 3 months. This can change, might need more frequently tested if, for example, the patient has any vomiting, diarrhea or acute illness. Some other points of monitoring that we need to do is look out for the patient's thyroid test, liver function test, renal function, and any signs of bleeding such as nosebleeds. Bruising is quite common with patients that are on all anticoagulants. We want to make sure the patient is aware that they look out for any signs of thrombosis. So this can come in the form of, say, pain, swelling or redness, particularly around their calves. Now warfarin should be taken ideally at the same time every day. In hospital settings, it's usually given at 6 p.m. And with the warfarin tablets, they're each associated with a different colour. So warfarin 1 mg is brown, warfarin 3 mg is blue, and warfarin 5 mg is pink. You can also get warfarin 0.5 mg as well, so be careful whenever you are dispensing or checking warfarin that it is 5 mg or 0.5 mg. Don't get those two mixed up. Now, say a patient misses their dose of warfarin on a Monday, then when it comes to Tuesday, they shouldn't double their dose. That dose of warfarin that was missed out on the Monday, that should be omitted, and they should just carry on taking their warfarin as they regularly do going forward. There's no need for them to double the dose, and so make sure you make your patients aware of that. And patients on warfarin should ideally have an alert card that they keep on them at all times, and say they go for like a dentist appointment or a hospital appointment which isn't related to their warfarin, then at least whoever the prescriber or whoever is treating them can see that, oh, okay, this person is on warfarin. So whatever procedures that they were intending to do would have to be adjusted accordingly. Next, we move on to amiodarone. So amiodarone, say a person starts taking it and then they start saying to you, you know what, I've been feeling really weak, fatigued, putting on a lot of weight whilst I've been starting this amiodarone. Alarm bells need to be going because these are signs of hypothyroidism. Equally, a patient might say to you, oh, I've been finding it really hard to sleep. So they've been exhibiting signs of insomnia. They've been having increased sweat, heart palpitations. These are signs of hyperthyroidism. So a patient on amiodarone can potentially get hypo or hyperthyroidism. So we must make sure that we check regularly the patient's thyroid function levels. Or a patient could exhibit clinical signs of liver disease, such as jaundice, or even complain of a progressive shortness of breath, which could indicate pneumonitis. So we need to make sure that we're testing a person's liver function and giving them chest x-rays. A key counselling point with patients that are on amiodarone is to make sure that they avoid excessive sun exposure, direct sunlight, because they can end up getting a discoloration of the skin and it ends up going this greyish sort of colour. As well as that, if they're a driver, then they can be dazzled by bright lights. There is a potential for that. Now, amiodarone has a half-life of 50 days, so a very long half-life. And it means that even when a person stops taking amiodarone, the clinical effects of amiodarone can still linger about in their body. So then if a patient starts taking, say, Digoxin or dabigatran, there is a potential that because the amiodarone is still lingering about somewhere in the body, there is that potential for an interaction, so keep that in mind. And amiodarone is one of our medication where if a patient is also on simvastatin, the dose of simvastatin should not exceed 20 milligrams, otherwise they're at an increased risk of getting myopathy. And when amiodarone is given with beta blockers, diltiazem or verapamil, they're at an increased risk of bradycardia or even an AV block. Antihypertensives, so your blood pressure medication. So some of the key things that we need to monitor with a person on their blood pressure medication is, of course, blood pressure, as well as renal function and serum electrolytes. Now, something like amlodipine, it can cause swelling in the ankles, edema, so we need to look out for any signs of water retention. The patient might exhibit dizziness or even excessive thirst or urination. Now, if a patient is taking blood pressure medication for the first time or their dose has been increased recently, then it's really important that we counsel to them that when they've been lying down or sitting down for a long while, they get up very slowly, because this can then avoid signs of postural hypotension. As well as that, they might benefit from having a glass of water before they get up. As well as that, when it comes to over-the-counter medication, remember, it's really key to ask patients those WHAM questions, particularly, are you on any other medication? Because if a person is on blood pressure medication and they want an indigestion remedy, such as Gaviscon, or they want a cough medicine, or they want an analgesic, a soluble analgesic, a lot of these products contain a high sodium content, so a high salt content. So be wary if a patient is on blood pressure medication and they want these kind of products. And particularly with diltiazem and nifedipine, patients need to stay on the same brand of medication. It shouldn't be interchanged. And particularly with calcium channel blockers, patients should avoid grapefruit, those orange, grapefruit, bitter tasting grapefruit juice, because it can increase the plasma concentration of calcium channel blockers in the body. So next we move on to carbamazepine. It's one of our epileptic medication. So ideally the therapeutic range of carbamazepine is between 4 to 12 milligrams per litre. Now, carbamazepine is one of those medications where a patient needs to stay on the same brand. It shouldn't be interchanged. And we need to know what laws are in place with regards to driving and epileptic medication. So a person needs to have been seizure-free for at least 1 year. If they do get attacks, then it should only be asleep attacks and not awake attacks, and that should have been established over a 3-year period. And if a patient is being withdrawn from the medication or any changes are being made to the epileptic medication, then during this period they should avoid driving, as well as for 6 months after that. Some of the signs of toxicity that can occur with carbamazepine is, for example, it's a lot of eye stuff. So blurred eyes, seeing double vision, uncontrolled movement of eyes, as well as nausea, vomiting, hyponatremia. If a person suddenly gets any unexplained bruising, sore throats, fever, rashes, this could indicate blood disorders, so it's important that we do monitor a patient's full blood count. They need to watch out for any signs of hepatitis, so we would need to look at their liver function as well as their renal function. There is something called anti-epileptic hypersensitivity syndrome, and if a patient has this, some of the symptoms that they would exhibit would be, for example, swollen lymph nodes, as well as a fever and a rash. Medications such as clarithromycin and erythromycin have an inhibiting effect on carbamazepine. So if it has an inhibiting effect, it means that it's not letting the carbamazepine run out of the body, so it's increasing the plasma concentration of carbamazepine in the body. Whereas something like phenytoin, it has an inducing effect on carbamazepine. So what it does is it acts as a cheerleader, and it's like, hey, carbamazepine, come on in, go on out, come on in, go on out. And so it's having because the carbamazepine is coming in and out of the body so quickly, it decreases overall the plasma concentration of carbamazepine. Next section is chemotherapy medication, and chemotherapy medication can be given in various forms, so IV, subcutaneously, intramuscularly, intraarterially, don't know if that's a word, intraarterially. Well, if it's not a word, it should be a word. but intra-arterial. It can be given in various forms. And if you go onto my malignant disease video, skip to 9 minutes 27 seconds, I go in great depth about cytotoxic medication and the side effects that they can bring on. So definitely check that out, because chemotherapy medication is cytotoxic, so it's very relevant to that. Just some key ones to briefly mention are, for example, extravasation of IV drugs, nausea, bone marrow suppression, and oral mucositis. So it's really important that a patient maintains good oral hygiene, brushing their teeth at least 2 or even 3 times a day with a soft bristle brush. Maybe rinse their mouth out more frequently to ensure that they avoid getting oral mucositis. Now, there is a life-threatening complication of chemotherapy medication known as neutropenic sepsis. Some of the symptoms that a patient may exhibit if they do get this is a really high temperature, above 37.5 degrees, flu-like symptoms, bleeding of the gums or nosebleeds, uncontrolled vomiting, diarrhea, and if a patient does exhibit any of these symptoms, they need to go to A&E ASAP. And actually, paracetamol should try and be avoided giving to these patients unless a medical professional says that they can. The reason for this is because it could potentially delay treatment of antibiotics being started. But yeah, any of these kind of symptoms, A&E, need to go straight away. So if you have a look at the GPHC framework and look under high-risk medication, one of the examples that they want you to be aware of are medicines that have a narrow therapeutic range. And an example of that is our Digoxin, because the therapeutic range for that is 1 to 2 micrograms per litre. But even that's the case, if it's between 1.5 to 3 micrograms per litre, there is potential risk of toxicity. So we need to know the signs of toxicity. They are, for example, nausea, vomiting, palpitations, blurred yellow vision, changes in weight. And another key monitoring point with Digoxin is our serum electrolytes, particularly potassium, magnesium, and calcium. So say you have a patient that is on a loop or thiazide diuretic, that's going to lower down their potassium levels. If they're on Digoxin as well, that's also going to lower down their potassium levels. They're going to get this risk of hypokalemia, and if they get hypokalemia, that increases their risk of getting cardiac toxicity. So we need to make sure that we monitor their heart rate as well. So how can we avoid hypokalemia? Well, we can maybe switch the person onto a potassium-sparing diuretic instead. Might need to give them potassium supplements, or give them good old bananas. They'll be getting their one of their 5 a day as well. And Digoxin is renally excreted, and their renal function is the most important determinant of their Digoxin dose. Another high-risk medication is something like our antibiotics, in particularly Gentamycin. Gentamycin has a therapeutic range between 5 to 10 milligrams per litre, and the 2 main sort of warning signs that we need to look out for Gentamycin is nephrotoxicity and ototoxicity. Nephrotoxicity because it's renally excreted, so we need to monitor the patient's renal function. And if, say, a patient starts taking Gentamycin and then they start complaining of any hearing disturbances or hearing loss, that's going to indicate ototoxicity. So they would need to seek medical attention ASAP. Another key counselling point with Gentamycin is that the patient stays adequately hydrated. We don't want them to get dehydrated whilst on the Gentamycin. Again, goes back to nephrotoxicity. So an example of a medication that increases the risk of nephrotoxicity with Gentamycin is cyclosporin. An example of a medication that increases the risk of ototoxicity with Gentamycin is something like our loop diuretics. Now let's move on to insulin. So with insulin, the patient needs to measure their blood glucose and we need to monitor their HbA1c levels. Now, with a diabetic on insulin, we need to make sure that the patient is aware of signs and symptoms of hypoglycemia. And I've had other practitioners who have seen a person have a hypoglycemic attack firsthand. The way that they describe seeing someone with hypoglycemia, it's as though they're drunk. So they seem quite confused, disorientated, sweating, which I think is quite a good way to remember the signs and symptoms of hypoglycemia. Just think of somebody drunk, because like I said, the symptoms and signs are very, very similar. We also need to make sure that we counsel the patient on signs of diabetic ketoacidosis, so nausea, vomiting, fatigue. Now let's move on to insulin. So with insulin, we need to monitor a patient's blood glucose and their HbA1c levels. Now, if a patient is on insulin, we need to make sure that they know the signs and symptoms of hypoglycemia. Now, I've had other practitioners say to me that when they've seen a hypoglycemic attack firsthand, it kind of looks like the person is drunk. So I think that's kind of a good way to trying to remember what the signs and symptoms are of a hypoglycemic attack, because if you just think of a drunk person, it's the same sort of symptoms. So, for example, they are quite confused, disorientated, sweating. We also need to make sure that we counsel the patient on signs of diabetic ketoacidosis, so drowsiness, nausea, vomiting, as well as making sure that they can look out for any signs of liver toxicity, heart failure, or pancreatitis, such as jaundice or abdominal pain. And if a diabetic presents to you with any retinal problems, so eye problems, or ulcers on the feet, they need to be referred. And it's really important that if you get a prescription for insulin, the prescriber has written the word units. They haven't abbreviated it to IU or just the letter U. It needs to say units. That needs to be really clear. And if a person is on insulin, then they need to have something called an insulin passport and notify the DVLA if they intend to drive or get their license and they're on insulin. Because remember, there are a lot of legalities that are surrounded diabetics and driving. If you have a look at my my endocrine video, I've explained it all in there. So check that out. Examples of medication that can increase the risk of hypoglycemia whilst taking insulin are, for example, oral anti-diabetic medications such as metformin and even ACE inhibitors. Whereas medication that increases the need for insulin requirements includes thyroid hormones, corticosteroids, or even oral contraceptives. So now let's move on to lithium. And lithium, again, is another example of a medication with a narrow therapeutic range. So ideally, we want it within 0.4 to 1 millimoles per litre. Anything above 2 millimoles per litre could lead to serious toxicity. Now, the main 3 monitoring areas that we look at in a person that's on lithium is their cardiac function, thyroid function, and their renal function. So in terms of signs and symptoms of toxicity, a person could, for example, display signs of hypothyroidism. Hence, we need to look at their thyroid function. In terms of their kidneys, in really serious cases, patients could have renal failure. So we need to look out for any signs of changes to their renal function, for example, polyuria, polydipsia. And in terms of their cardiac function, we need to look out for any arrhythmias or changes to their blood pressure. As well as that, we need to counsel patients on if they display any visual changes or visual disturbances or persistent headaches, because this could indicate intracranial hypertension. Now, with persons on lithium, there's some dietary advice we need to give to them. So they need to maintain an adequate fluid intake. They can't get dehydrated. They need to keep hydrated. And they need to try and reduce their salt intake. We don't want to be giving them any excess salt. Again, it goes back to our over-the-counter preparations. So Gaviscon or soluble analgesics, they all contain high salt contents, which is why it's so important that we ask those WHAM questions to our patients. As well as that, they should avoid alcohol. And lithium is one of those medications where a patient needs to stay on the same brand. Brands shouldn't be interchanged. So medications such as diuretics, NSAIDs, ACE inhibitors, they all want to keep, if they're given with lithium, they want to keep lithium in the body. So they reduce the excretion of lithium, and because of that, then the plasma concentration of lithium stays high in the body. Whereas something like aminophylline or aminophylline, however you pronounce it, that has the opposite effect. So it wants lithium to go out of the body. So it's like, buy lithium, and so it increases the excretion of lithium, and because of that we have a reduced plasma lithium concentration in the body. So moving on to methotrexate. Now with methotrexate, it's a once a week medication, so it's not taken every day, just once a week. They pick a day, they stick to that day. With a lot of people on methotrexate, they also need to take folic acid as well, and that should be given on a different day to that of the methotrexate. So the methotrexate and folic acid should not be given on the same day. Also with methotrexate, only one strength should be prescribed and dispensed at one time. So just the one strength. It's not like warfarin where a patient could be on warfarin 1 and warfarin 3. They should only be on that one strength of methotrexate, for example, methotrexate 2.5 milligrams. And if they need to make a dose of 8 milligrams, they need to make up that 8 milligrams using those 2.5 milligram tablets. Now with methotrexate, we need to monitor patients' full blood count, renal function and liver function. So if a person displays any symptoms, for example, liver toxicity, so jaundice, nausea, vomiting, or any signs of bone marrow suppression such as fevers, sore throat, rashes, they need to tell their doctor straight away, need to seek medical attention straight away. As well as that, patients on methotrexate should avoid NSAIDs and aspirin, and they should also avoid live vaccines. Moving on to opiates. So opiates is used as pain relief. So we're going to monitor patients' pain, level of sedation, and even how nauseous they're feeling. Also, I would also add in how constipated they are as well, bowel habits, because opiates can be quite constipating to quite a few people. So some of the warning signs though that we need to counsel our patients on are, for example, respiratory depression, so if they're getting any breathlessness, as well as that they would need to look out for any extreme tiredness, because as mentioned, they can be sedating, but when they're extremely tired, that's a warning sign. Any pinpoint pupils, convulsions, and any blue discoloration, particularly of the lips, the ears, or the nose. If a patient does experience any of these warning symptoms, they need to seek medical attention immediately. And a patient should avoid driving, especially if they are experiencing that extreme tiredness. Another point worth mentioning when it comes to opiates is that, especially if a person's on it long term, they can get dependent and tolerant on the opiates, so that's something to bear in mind. And finally, on to NSAIDs. So with our NSAIDs, we need to monitor liver function, renal function, and even blood pressure. And with our NSAIDs, the two key warning symptoms are those related to GI and those related to cardiovascular side effects. So if a person exhibits black stools, coffee ground vomit, or iron deficiency, this could indicate a GI bleed. Patients should also report any unintentional weight loss, swelling of the ankles, or if their asthma worsens, because in some asthmatics, if you give them an NSAID, that can exacerbate their asthma symptoms. With NSAIDs, remember to give the key counselling point that should be taken with or after food. And again, as mentioned before, if you're giving it over the counter, make sure that that NSAID isn't going to interact with anything else that the patient is already taking. When given with quinolones, there is an increased risk of convulsions in patients. There's an increased risk of bleeding if it's given with SSRIs or dabigatran. And when given with either lithium or methotrexate, it reduces the excretion of these medication, which as a result increases the plasma concentration of, say, lithium or methotrexate, therefore leading to toxicity. So this video focused on a main summary of high-risk medications that are included in the GPHC framework. But I mean, there are other medications outside of those ones that could potentially be classified as high risk. For example, diuretics, corticosteroids, or even other anti-epileptic medications such as phenytoin. So bear that in mind when covering this particular chapter. So I hope you found this video useful, and if you did, why not give us a like, share, subscribe, visit my Facebook and Twitter page, and until next time, good luck with your revision and happy revising!